Intestine, Part 3. Intestinal obstruction. Definition: arrest of downward propulsion of intestinal contents. Classification: according to the pathological nature of the cause and according to the level of obstruction. According to the level of obstruction, high small bowel obstruction and low small bowel obstruction. According to the pathological nature of the cause, we have two types: simple mechanical obstruction, strangulation obstruction, and a third type called paralytic ileus. Simple mechanical obstruction caused by an organic block leading to acute abdominal pain. Strangulation obstruction, significant impairment of the blood supply leading to ischemia. If not relieved within 6 hours, gangrene occurs, and it may result from volvulus, which is twisting of the intestinal blood supply upon itself, or constriction of the blood flow by a tight band or a hernia opening, or thrombosis or embolism of the mesenteric vessels. Paralytic ileus, it's due to the loss of bowel propulsive power leading to functional obstruction. According to the onset and course of obstruction, we have acute obstruction, chronic obstruction, and acute on top of chronic obstruction. Acute obstruction, rapid course, and early symptoms. Chronic obstruction, such as colon cancer, gradual symptoms and slowly progressive. The patient has constipation and distension. Acute on top of chronic obstruction may develop acute symptoms when a narrowed lumen becomes totally occluded as by dry stools. Acute mechanical intestinal obstruction, general principles. Causes: in the lumen, fecal impaction, gallstone, and parasitic infestation. In the wall, we have congenital atresia, tumors, Crohn's, chronic diverticulitis, and mesenteric vascular occlusion. Outside the wall, we have adhesions, commonly post-operative, strangulated hernia, and volvulus. Pathology: for the simple obstruction, distal to the obstruction, the intestine empties and becomes collapsed. Proximally, the intestine becomes distended by gas and fluid. Gas due to swallowed air in 68%, diffusion from congested vessels in 22%, and bacterial fermentation in 10%. Fluid due to GIT secretions, which are 8 liters per day. As the intraluminal pressure rises, absorption ceases. Hyperperistalsis due to stretch of the smooth muscles to overcome the obstruction, increased both power and frequency of contractions. Impaired blood supply due to distension, leading to ulceration and perforation. Examples: closed loop obstruction, colon obstruction with a competent ileocecal valve. When pressure rises in the closed segment, perforation of the cecum occurs. Pressure of an adhesion band or the edge of a hernia defect in the bowel wall leads to local ischemic necrosis leading to perforation. Strangulation obstruction: in addition to the above, we have unrelieved strangulation leading to ischemia, gangrene, perforation. Bacteria and toxins reach the peritoneal cavity leading to peritonitis. Or unrelieved strangulation can lead to septic shock. The mucosa is the first layer to suffer from ischemia, so acute ulceration and intraluminal bleeding occur. If a long bowel segment is involved, we have massive blood loss. Common causes: according to age, we have for neonates, congenital atresia, volvulus neonatorum, anorectal malformations, meconium ileus, and Hirschsprung's disease. Infants, we have ileocecal intussusception and Hirschsprung's disease with strangulated hernia. Adults, we have adhesions and strangulated hernia. Elderly, colon carcinoma and strangulated hernia. Strangulated hernia is a common cause in different age groups. The most common cause of small intestine obstruction. In adults, it's adhesions. In children, strangulated hernia. The most common cause of large bowel obstruction is colon cancer. Lethal effects: fluid and electrolyte loss from vomiting and accumulation in the proximal bowel, septicemia from peritonitis. Clinical picture: symptoms: pain. This is the first symptom. It's colicky caused by the hyperperistalsis. Distension: in colon obstruction, it's marked and present mainly in the flanks. In high obstruction, it's less marked and absent, maybe in some cases. In low small bowel obstruction, we have central abdominal distension. Absolute constipation, it's failure to pass flatus in addition to stools. It's early in colon obstruction but late in high obstruction. Vomiting, it's early in high obstruction, but late or absent in colon obstruction. In neglected cases, it becomes greenish, then brown and offensive, meaning feculent, but it's not fecal. Signs: general examination, evidence of dehydration such as tachycardia, oliguria, dry tongue, or even hypotension. Abdominal, we have inspection, distension and visible peristalsis. Look for strangulated external hernia, and scars of previous abdominal surgeries may denote intra-abdominal adhesions. Palpation, a mass may be felt, whether tumor or intussusception. Auscultation, accentuated intestinal sounds, and by direct rectal examination, it reveals empty rectum. An exception is finding a hard fecal mass in an elderly bedridden patient causing fecal impaction. Pain, distension, vomiting, and absolute constipation are the cardinal symptoms of acute mechanical intestinal obstruction, but not necessarily present in all cases. Strangulation needs urgent surgery, and it's suspected in pain, which is not relieved by nasogastric suction. The pain is partially caused by hyperperistalsis and partially by ischemia. Decompressing the bowel doesn't relieve the ischemic pain. Signs: general, toxic patient, fever, leukocytosis, evidence of blood loss, whether by pallor, tachycardia, hypotension, and local we have marked tenderness and rebound tenderness with rigidity. Investigations are needed to confirm the diagnosis of the intestinal obstruction, to define its level and cause, to estimate the severity of water and electrolyte imbalance. Questions to answer for clinical assessment of intestinal obstruction. Number 1. Is there intestinal obstruction in the first place? Intestinal obstruction is diagnosed by the presence of colicky abdominal pains, distension, vomiting, and absolute constipation. What is the pathological type of obstruction? We have strangulation, and in paralytic ileus, strangulation is suspected when there is a severe pain not relieved by bowel decompression or nasogastric tube, toxemia, abdominal tenderness, and rigidity. In paralytic ileus, there is no pain and the bowel sounds are absent. Number 3. What is the level of obstruction? In high small bowel obstruction, we have early vomiting and dehydration, and there is slight abdominal distension, while in low small bowel obstruction, the vomiting is delayed for 12 hours and there's central abdominal distension. In colonic obstruction, early constipation while vomiting may be absent or occurs after a few days. Distension is marked especially in the flanks. What is the cause of obstruction is the fourth question. It's suspected from the age of the patient and by the presence of certain physical signs such as presence of appendectomy scar, which means adhesive intestinal obstruction. Investigations: radiological and laboratory. Laboratory: CBC, blood urea, and electrolytes. Radiological: plain X-ray of the abdomen. Erect film: it shows multiple gas fluid levels to confirm the diagnosis. Supine film: showing the level by the gas pattern of the distended proximal intestine. Distended jejunal loops leads to characteristic circular mucosal folds called valvulae convex and crossing from one side of the lumen to the other. Distended ileal loops, featureless tubes with no mucosal pattern, and a colon full of gas leads to hostrations which don't reach the other side of the lumen. Ultrasound examination, it can reveal distended bowel loops, and a mass of intussusception can also be demonstrated. CT scan with contrast, it has a high sensitivity from 80 to 90% for the diagnosis of intestinal obstruction. Treatment: urgent relief of obstruction by surgery after adequate preoperative preparation. Preoperative preparation: drip and suck. IV line, replacement of fluid and electrolytes, blood and plasma if the patient is shocked. Ringer's lactate solution is needed. Antibiotics are given if there is a possibility of strangulation. Gastric aspiration by nasogastric tube to decompress the bowel and to reduce the risk of inhalation during induction of anesthesia. A Foley catheter to check the urine output. Operation: a longitudinal exploratory incision is performed except in strangulated hernia. The incision is directly over it. And then we have exploration. First, look at the cecum. If it's collapsed, then this means small gut obstruction. If distended, this means large bowel obstruction. Determine the level of obstruction, which is the junction of dilated and collapsed bowel loops. Relieving the obstruction by division of adhesive bands, reduction and repair of a hernia, or untwisting of volvulus. Assessment of the bowel viability. Viable reduced to the abdomen. Doubtful bowel, wrap it in hot bags for a few minutes and it may recover. For non-viable intestine, resection and then according to the site. Small intestine, primary anastomosis, and in the colon, right colon, primary anastomosis, left colon, temporary colostomy, Hartmann's or Micolics, and then restore continuity after a few weeks after proper preparation. Conservative treatment, adhesive intestinal obstruction, IV drip and nasogastric suction, ileocecal intussusception, a barium enema. It has hydrostatic effect and the reduction is radiologically monitored on the screen. Sigmoid volvulus, a rectal tube is passed through a sigmoidoscope and can untwist the obstructed segment. Fecal impaction, enema, dissolve the obstructing hard fecal mass. Indications of conservative treatment, case is early or there is no clinical evidence of the intestinal ischemia. Failure of conservative treatment and suspicion of strangulation means that the surgery is indicated. Non-viability of the intestine is known by loss of peristalsis, loss of normal luster, color change to greenish or black bowel, this means it's non-viable. Purple bowel means still recovering. Loss of pulsations in the mesentery. And then we have acute mechanical intestinal obstruction, special forms. Neonatal intestinal obstruction is discussed in the pediatric surgery. Intussusception. An intussusception, definition, invagination of an intestinal segment, intussusceptum, into the lumen of an adjacent one which is the intussuscipient. Types, ilioileal, ileocecal, ileocolic, colocolic. Ilioileal, a loop of ileum invaginates itself into an adjacent ileal loop. Ileocecal, the commonest type and usually affects infants. The terminal ileum invaginates into the colon with ileocecal valve repressing the apex of the intussusception. Ileocolic, an ileal loop invaginates into ileal loop and then passes to the colon through ileocecal valve. The blood supply of the ileal loop is tightly compressed by the ileocecal valve. Colocolic, a loop of colon invaginates into an adjacent colonic segment. Etiology, in adults, there is an evident cause at the head of the intussusceptum such as polyp, Meckel's diverticulum, submucous hematoma in Henoch-Schlein purpura. An intussusception is composed of inner tube and a returning tube, which is the intussusceptum, outer tube, intussuscipient. The blood supply of the inner layers of the intussusception is liable to be impaired at the neck of the intussusception. Adhesive intestinal obstruction. Incidence, the commonest cause of intestinal obstruction in adults in developed countries. Etiology, post-operative and post-inflammatory. Post-operative, this is the commonest. Exact etiology is unknown, but it is suggested that adhesions develop at the sites of ischemia of the bowel or at the obstruction scars of the abdominal wall. Post-inflammatory, it follows previous septic or tuberculous peritonitis. Pathology, adhesions may be multiple or solitary. They bind one intestinal loop to the other, or to the abdominal wall. They induce obstruction by kinking or directly obstructing a small intestine loop. Strangulation may result from compression of the loop's blood supply or a band leading to direct pressure on the intestine at the level of the block, leading to localized ischemic necrosis. Adhesions have a tendency for recurrence, producing recurrent intestinal obstruction. Clinical picture, acute or recurrent acute small bowel obstruction, colicky abdominal pain, vomiting, distension, and absolute constipation. Those are the cardinal symptoms. Almost always there's a scar of previous abdominal surgery and there may be physical findings of strangulation. Treatment, conservative treatment and surgery. Conservative treatment indications are early cases without any evidence of strangulation, particularly if it's a recurrent obstruction. Method, nasogastric suction and IV replacement of losses, drip and suck. The main lines of conservative treatment: close observation to judge success, which is indicated by resolution of pain and distension, passage of flatus, and retrieval of clear gastric aspirate. Conservative treatment shouldn't be prolonged if there is no response in 48 hours. Surgery indications: if the conservative treatment fails or there is evidence of strangulation or gangrene, at operation adhesions are divided and the bowel viability is assessed and dealt with accordingly, as we have previously mentioned. Volvulus, definition: twisting of a bowel loop around its mesenteric axis. Pathology: producing a combination of closed loop obstruction and occlusion of the main vessels at the base of the involved mesentery, strangulation. In a closed loop, the pressure rises rapidly, leading to gangrene and perforation. The commonest site is the sigmoid colon, and it may affect cecum, stomach, or small intestine. Predisposing factors: a long sigmoid colon, a narrow base of sigmoid mesocolon, heavily loaded sigmoid as a result of chronic constipation, adhesions at the apex of the sigmoid loop, facilitating its twisting. Clinical picture: type of the patient, commoner in elderly, chronically constipated males. Symptoms: colicky pain, marked distension due to accumulation of fluid and gas in the closed sigmoid loop, absolute constipation, and finally, vomiting. Neglected cases show evidence of peritonitis. Signs: inspection, we have marked distension. Palpation, tense balloon of volvulus. Percussion, tympanic resonance. Auscultation, mad abdomen. And direct rectal examination, we have empty rectum. Investigations: plain X-ray, omega loop, the huge gas-filled sigmoid colon, which may look like the inner tube of a car tire. The base of the distended loop points to the left lower abdomen. Laboratory, we have CBC, urea, and electrolytes. Treatment: conservative treatment. Indications: in early cases without any evidence of gangrene, the method is rectal tube is passed through a sigmoid scope to untwist the sigmoid loop. Success is known by a gush of gas and fluid stools. The tube is left in place and the patient is prepared for later elective resection of the long sigmoid to prevent recurrence. Surgery. Indications: failure of the conservative treatment, late presentation. Method: if the colon is gangrenous, resection. The proximal colon end is brought out to the skin as a terminal colostomy, and the distal end is closed by sutures, Hartmann's procedure, for later elective anastomosis. Viable sigmoid, it's untwisted. If short, it's fixed to the posterior abdominal wall. If long, it's resected, as for gangrenous cases. Paralytic ileus. Definition: failure of the neuromuscular mechanism, failure of the peristaltic waves of the intestine, leading to adynamic obstruction. Some degree of bowel atony follows abdominal operations for 24 to 48 hours. Paralysis which extends for more than 3 days deserves search for another cause, hypokalemia or leaking anastomosis, which leads to peritonitis. The duration of post-operative reflex ileus depends on the bowel manipulation and irritation by blood, bile, urine, or pus. Etiology of the paralytic ileus: reflex inhibition of the intestinal motility following spine fractures, hyperextension of the spine in plaster jacket, retroperitoneal hemorrhage, and finally, which is the most common cause, major abdominal operations. The exact mechanism is not known, but probably it's due to sympathetic overaction. Metabolic abnormalities such as hypokalemia, uremia, and diabetic ketoacidosis. Peritonitis induces direct toxic effect on the nerve plexuses of the intestine, but it may be complicated by formation of fibrinous adhesions, leading to kinking of the intestinal loops, adding mechanical obstruction. Drugs, as anticholinergics such as probenthine and tricyclic antidepressants if taken in large doses. Pathology: marked distension of the small and large bowel with gas and fluid. The patient suffers a severe loss of fluid and electrolytes in the distended bowel through vomiting. The patient has no colicky abdominal pains, but there is only sense of fullness and discomfort. There may be evidence of localized or generalized peritonitis. Clinical picture: symptoms and signs. Symptoms: abdominal distension, absolute constipation, effortless vomiting. Signs: inspection, abdominal distension, auscultation, inaudible intestinal sounds, which means silent abdomen. Investigations: laboratory, CBC, blood urea, and electrolytes, plain X-ray of the abdomen, multiple gas fluid levels. The gaseous distension includes the whole small and large intestines. Prevention: preoperative, intraoperative, and postoperative. Preoperative: prevention and correction of biochemical disturbances. Hypokalemia is prevented and treated by IV potassium guided by serum level. Intraoperative: gentle handling of the intestine. Postoperative: for major abdominal surgeries, a nasogastric tube to decompress the bowel. Treatment: IV replacement of the lost fluids and electrolytes with nasogastric suction, drip and suck. Those are essentials. Correction of the metabolic abnormalities and hypoproteinemia. If a post-operative ileus is prolonged for more than 3 days, think of peritonitis from a leaking intestinal anastomosis or mechanical obstruction from early fibrinous adhesions, and those two necessitate reoperation. The above measures are usually successful, but occasionally in resistant cases we use a parasympathomimetic as prostigmine. Management of intestinal obstruction, nasogastric suction, IV fluid, Foley catheter, and prophylactic antibiotics. If there is evidence of strangulation, urgent surgery. Simple mechanical obstruction, surgery. In adhesive intestinal obstruction, we try conservative treatment. For paralytic ileus, conservative treatment. Rectal prolapse. Definition. Protrusion of the rectum through the anus. We have partial and complete. Partial or mucosal rectal prolapse, the mucosa only prolapse, and the incidence is common in children. Etiology. In children, loss of the curve of sacrum, the anus, and rectum, leading to a vertical tube. Loss of weight results in loss of the supporting pararectal and ischiorrectal fat. Straining at defecation due to prolonged diarrhea or whooping cough. In adults, it's due to urethral stricture leading to continuous straining, atony of the sphincter in the elderly, iatrogenic injury of the anal musculature during a fistula operation, or advanced cases of hemorrhoids. For complete rectal prolapse, definition, whole thickness of the rectal wall is prolapsed, incidence, more in elderly and more in females than males. In Egypt, males affected more due to bilharziasis of the rectum. Etiology. The exact etiology is unknown. Many theories are suggested, such as failure of rectal support by levators and pelvic fascia due to defective collagen maturation in the pelvic floor. Excessive stretching of those structures during labor may explain its association with childbirth. Number 2, it may represent a sliding type of hernia. Most patients have a deep rectovesical or rectovaginal extensions of the Douglas pouch. Number 3, abnormal mobility of the mesorectum, lack of fixation between the rectum and sacrum. Pelvic floor. Number 4, denervation, secondary to repeated childbirth. Number 5, intussusception, which starts 10 centimeters from the anal verge. And number 6, in Egypt, bilharzial proctitis and colitis leads to continuous tenesmus and straining at defecation, especially if there is bilharzial ulcers and polyps. Clinical features for both, they are the same whether partial or complete. Symptoms: prolapse, it appears on straining and defecation. Early phases, they reduce spontaneously. Later, manual repositioning. Mucus discharge, bleeding from the congested mucosa and discomfort. A degree of fecal incontinence, common with complete rectal prolapse, is the distressing symptom which urges the patient to seek medical advice. And finally, complications as irreducibility, ulceration, and gangrene. Signs: the patient is asked to strain to demonstrate his or her complaint. Squatting position is required if the prolapse doesn't show in the lateral position. The anal sphincter tone is also assessed by palpation. Pathology: for the partial prolapse, the length is less than 5 cm, mucosal corrugation is absent, thickness, mucosa. And for complete rectal prolapse, the length is more than 5 cm, mucosal corrugation is oftenly present, and the thickness is whole rectal thickness. Differential diagnosis for both, we have prolapsing polyp, prolapsing hemorrhoids, and prolapsing intussusception. Treatment: for children, surgery is rarely indicated. The condition resolves spontaneously with age. Instructions: avoidance of constipation and straining, improving nutritional status, manual reduction after defecation, followed by strapping of the buttocks to prevent prolapse, postpone child training to defecate in the putti. Submucous injection of 5% phenol in almond oil in resistant cases. Adults, mucosal prolapse, early cases, submucous injection of 5% phenol in almond oil, and in large prolapse, excision, similar to hemorrhoidectomy. Complete prolapse, it requires special surgeries as rectopexy, ventral rectopexy, sigmoid resection and rectopexy, perineal proctectomy, Delorme's operation, and narrowing of the anus, which is Tersch operation. Rectopexy, through abdominal approach, the rectum is mobilized and pulled up. A rectangular piece of polypropylene mesh or evolum sponge is attached by sutures to the presacral fascia, then wrapped and sutured around the back and sides of the rectum. The mesh initiates fibrous tissue and then fixes the rectum in its new position. Ventral rectopexy is a newer option. The anterior plane is mobilized, a permanent mesh is secured to the anterior rectal wall at the level of pelvic floor, then the mesh is anchored to the sacral promontory. Advantages: lower complication rates, central recurrence rates, and improved functional outcomes. Sigmoid resection and rectopexy. Freckman-Goldberg procedure shortens the redundant rectosigmoid colon with posterior sacral fixation. Recurrence is less than 10% following rectopexy with or without resection. Perineal proctectomy, modified Altemierre procedure, alternative for patients with severe anal incontinence due to complete eversion and stretch of the anal canal. Recurrence rate is generally around 20%. Delorme's operation, done through transanal approach, circumferential excision of excess rectal mucosa above the dentate line. Sutures pass through the rectal muscle, plicating it to approximate the upper edge to the remaining mucosa of the dentate line. Narrowing of the anus or terse operation. Indications: frail patient who are unable to stand a major surgery. The prolapse is reduced and a stainless steel wire or a thick monofilament suture is tunneled subcutaneously around the anus. The suture is then tied to fit around the finger of the surgeon, and the simplest operation, but it provides poorest results. The results of operations are clouded by the proportion who get recurrence and by those who continue to have fecal incontinence, and this concludes the whole intestine.